Good evening. We have two diverse subjects. I don't know how they got bundled together, two completely different things. But anyway, we will have a short group discussion on parastomal hernia, and following that, it'll be a lecture. I don't think we have time for group discussion for the second part of this discussion, which is on surgical safety. It's also very important that we all focus on safety. But first, parastomal hernia, we will finish it fairly a short time. It's something that is important, but from a postgraduate's point of view, it will probably be some short notes for you, and so I don't think we need to delve into it in any great depth. Okay, now we start with what a parastomal hernia is. We'll ask the youngsters. Malavika, have you read up about it? What is a parastomal hernia?
Sir, parastomal hernia is the protrusion of the abdominal contents through the abdominal wall defect, which is adjacent to the stoma, uh, created for colostomy, ileostomy, like that.
Correct. Completely correct. Okay, it's a kind of an incisional hernia basically, where the contents protrude through an abdominal defect created for a stoma, either a colostomy, ileostomy, or a urostomy. Okay, what do you think is the incidence of this disease? How often do you get it? If you don't know, say you don't know.
Sir, a 30%, sir.
30%, right? Okay, when does it happen after you fashion the hernia? Generally,
It's a long-term complication.
long term. Okay, it's about a quarter to half the time. It can be as high as 50%. Most occur within 2 years, and it increases with time. The longer you follow them up, higher is the incidence of a parastomal hernia. Okay, so it's very, very common, much more than an incisional hernia from an abdominal wound. What is the average for an abdominal wound? Karthik, what is an incisional hernia for an abdominal wound, not a parastomal?
Um, no, no idea, sir.
Yeah, it's around 10 to 15%. The higher ranges are about 25 to 30%. But the average is 10 to 15%. So this incisional stomal hernia, parastomal hernia, is about twice as common as a regular incisional hernia. Okay. Now, what do you think are the risk factors, Samir?
Sir, we can divide the risk factors patient dependent on the surgical factors, sir.
Okay. Okay.
Patient dependent will be mostly age more than 60 years,
Correct.
obesity, and comorbidities like diabetes. If patient is already a known smoker, systemic and local inflammation,
Okay.
then uh, any immune disorders, collagen disorders,
Okay.
chronic cough, and if patient is on steroid therapy,
Right.
and um, then sir, the surgical factors will be like if the surgery itself is a urgent surgery type of stoma,
Mm-hmm.
and suture, and if we have used a mesh or not,
Mm-hmm.
and
Type of stoma, does it matter? What
sir,
what what is it? What is the type of stoma you're referring to?
sir, according to studies, they've told, sir, if it is a end colostomy or end ileostomy, it differs.
Mm-hmm. What is worse? Differs doesn't mean anything. Which is worse? Is colostomy worse or ileostomy worse?
Colostomy, sir.
Colostomy is worse. Okay. What
Um,
else?
and the techniques, sir, how stoma creation technique.
Right.
Yes.
Yeah. I
And
already mentioned the
the
technique here. Stoma fashioned lateral to the rectus. Okay. Whether you go through the rectus or lateral to the rectus, this is debatable, but that's one of the things that literature mentions. Okay. So the main ones are the female gender, age over 60, hypertension, obesity, and stoma fashion lateral to the rectus. Colostomy is generally worse than the ileostomy, but it can happen in both situations. Urostomy, not very common to have a parastomal hernia. Okay, so can you prevent parastomal hernias? What are the techniques that are described for that? Ines.
So, again, patient-related factors, sir. We
Mhm.
counsel them regarding maintaining their weight and trying to not to increase any condition wherein there will be an increase in intra-abdominal pressure,
Correct.
like constipation, and maintaining their nutritional status, sir,
Yeah.
so as to ensure strength.
Mhm.
And the other thing will be, sir, maintaining the stoma, like stoma care. So, ostomy binders can be used, sir.
Not very
Which
useful. Okay, you can use, yeah. Okay.
uh, so those can be the approaches, sir.
Okay. Anything else?
And so also while doing the procedure, do we we take into account the preference for stoma, sir?
Mhm.
The incidence for end colostomy is more in comparison to ileostomy.
You can't
So
avoid it. No, you
avoid.
have to do an end colostomy. It's not a preventable thing. You have to live with it. So what else can you do in the technique?
Also the diameter, sir. So
Good.
usually greater the ostomy radius is, the more will be the tangential force, which will cause the stoma to that
Yes.
is a
So what is your rule to decide the diameter?
uh, that I'm not sure,
All
sir.
right. Okay.
Yes, sir.
Okay. So these are the
Yes,
things
sir.
that you should think of. Okay.
Yes.
These are the things that you should think of. You mentioned weight management and you mentioned the diameter, which is very correct. There should be a snug fit of 2 fingers only. Okay.
Yes, sir.
What surgeons tend to do is to get the stoma out easily, they tend to overstretch the defect. So once you make the hole just enough to get the stoma out, even if as long as you don't cause stenosis of the stoma, that's fine. So just 2 fingers breadth is the rule of thumb. And as I said, the picture shows you here on this side of the screen. Bring it through the rectus rather than lateral to the rectus. This is debatable. Not everybody agrees with that. And what's called an extraperitoneal stoma? Karthik, what is an extraperitoneal stoma?
No idea, sir.
You don't know?
No, sir.
Okay. Sanya, you want to have a go at it?
Sir, tunneling of the stoma
Yes, that's
through the
correct.
peritoneum.
So you don't bring the peritoneal hole is much lateral to the skin and the muscle hole. If you understand that, you go very, very much lateral in the peritoneal hole, tunnel the whole bowel under the peritoneum, and then go through the hole in the muscle and the skin and subcutaneous tissue. Extraperitoneal stoma. But the most common thing that is used nowadays is the use of prophylactic mesh. Okay, you can actually use a mesh. This is an umbrella review of 19 systematic reviews, huge body of data. They looked at both clinical and radiological recurrences. As you know, the radiological recurrences are nearly twice as common as clinical recurrences. So these are studies which even looked at radiological recurrences, and they found that the mesh reduced the risk of parastomal hernia considerably, quite significantly. So because of the high incidence of parastomal hernias, I haven't practiced it because unless I find somebody who is very obese and where I have difficulty creating a stoma, I have not routinely used a prophylactic mesh, but that's something that one can seriously consider. Okay. The other thing that I
Sir,
have not
just a
even,
doubt, sir.
yeah, go on.
Sir, in case of the tunneling,
Yeah.
will it alter the movement of the content, sir?
It doesn't,
Technically.
unless you have, theoretically, you might think that might happen, but usually it doesn't happen. I'll talk to you about the treatment a little later, where something even more drastic is done. But because there is no acute kink, that it comes through a gentle curve. It doesn't cause any obstruction. Theoretically, it's possible, yes. And this is something which I hadn't even read about until I prepared for this talk. The stapled mesh stoma reinforcement, it's called SMART method, where the hole in the abdominal wall is made by a specialized EEA stapler. It's probably much longer than the usual EEA stapler. That's what I guess. And what you do is put it through. This is a mesh. You can see here it's a mesh which sits on the anterior rectus sheath. So you put the stapler through the end colostomy or even the side colostomy. You put the anvil into the bowel, and then the hole in the abdominal wall is not done mechanically with hands and stretching, but by the EEA. It seems to be promising. It's still new. I don't think we have mature data about it, but it is something that one has to think about, the so-called SMART method of making a stoma. Okay. And then once that is done, this mesh is sutured onto the anterior rectus sheath, and it's supposed to be good. Okay. So once you have the hernia,
Mesh.
sorry, go on.
Sir, so the mesh is in contact with the stomal opening, sir.
Yeah, I mean, it's around the thing, the mesh is lower down. You can see that this mesh will be in the anterior rectus sheath. The stomal opening will be at the skin level, and that will be sutured. You understand? There is a gap between the mesh and the actual opening. And so the stoma will be stitched
Yes.
onto the skin. Maybe an inch or so deep is the mesh, and the mesh will be stitched onto the anterior rectus sheath. Okay, did you get that?
Yes, sir. Yes, sir.
Yeah.
Got it, sir.
Yeah. So what do you think are the problems associated with a parastomal hernia? Samir, go on.
There can
Somebody. Yeah, go on, Anas. Yeah.
so like acute complications, wherein
Yeah.
a patient can present with bowel obstruction or strangulation,
Yes.
and there'll be like prolonged, like chronic symptoms,
Yeah.
wherein the stoma appliance is not fitting properly, which is resulting in persistent leakage,
Correct.
or and because of this, like if the surrounding skin is
Yeah.
getting
So,
ulcerated. So
the acute ones
yeah.
are obstruction and strangulation.
Yes.
The chronic ones are stoma malfunction. There will be
Yeah.
improper,
Quality of life.
improper functioning of the stoma. It doesn't empty well. Because of that, they have problems with smell. They can't fit the appliance, and they have skin problems and leakage. So a parastomal hernia has to be dealt with because of these problems. So what are those repair techniques that you are aware of? Karthik, you want to have a go?
Yes, sir.
Yeah.
One, we can go with a local facial repair, which has the highest recurrence rate.
Okay.
And the other thing is we can go with the stomal relocations.
Okay.
And that the third is the mesh repair, sir.
Yeah. Generally, you have a non-mesh repair, a mesh repair, and the so-called Sugar-Baker technique. Have you guys heard of it? It's a very well described old technique, nothing very new, and resiting the hernia. These are your choices, and you can go through each one of them. The important thing is when you have a defect like this, it is important to lateralize the stoma. Okay, so what you normally do is push the bowel, the stoma bowel, as it comes out of the posterior sheath, push it as lateral as possible and stitch up the posterior sheath on the medial aspect. That way you're lateralizing the stoma, and that is supposed to be the recommended method where the recurrence rates are lower. Okay, that is the no mesh technique. I don't do no mesh because I always use a mesh to repair it. The mesh can be as wide as you want it to be. It need not be as wide as is shown here. What the picture here shows, in addition to a mesh repair, a resiting of the stoma from one side to the other side. But you can do it on the same side. You can have a mesh which is extending, as we said, 5 centimeters on either side of the defect. which is the standard. It's usually placed in the extraperitoneal plane. And the important thing is that it goes on either side of the bowel. So you make a little hole in the mesh to accommodate the bowel and bring it out through the rectus onto the surface. And the principle is that you can stitch the posterior rectus sheath if you want. Put the mesh either retrorectally behind the rectus muscle or extraperitoneally. Commonest and the easiest thing to do is to put it extraperitoneally, and it should be at least 5 centimeters beyond the edges of the hernial defect. That is the principle that you use. Pretty straightforward to do, and this is the commonest technique that I use. And this is the so-called Sugar-Baker technique. Okay? It is an exaggeration of the extraperitonealization. Not only do you do an extraperitoneal approach, but you also put a mesh in the retrorectus or the extraperitoneal plane. So you can see, I hope you can see my, let me get my point, this is the bowel that's going here. Okay, it goes like this, goes lateral through the peritoneum and superior to the mesh. You can see that this is the mesh, okay? And this goes superior to the mesh, comes all the way and then comes out like that. Okay, you got that? This is a so-called Sugar-Baker technique. I haven't used this, but this is something that will that is supposed to reduce the incidence of a recurrence of a hernia. As you can see, this also has been practiced elsewhere, even though I have not done it. And incidence of obstruction is not very common. So you can continue, it's one needn't worry too much about it, but make sure that all your the passage of your bowel has a smooth curvature rather than an acute kink. What do you think would be the surgical outcomes of repair of a parastomal hernia? Samarth? Samir rather, not Samarth.
Sir, sir, is it according to the repair, sir, or like just primary repair will have a recurrence?
According to the repair would be too much of a question for postgraduates. Overall, just list them and just give you an idea of what the incidence is going to be.
Only primary repair will have a high recurrence, around 50 to 60%.
50, 60%. I think you're pulling a fast one. Yeah, okay. What else? Okay,
And
go on.
mesh
Recurrence.
repair has the lowest one, so 10,
Okay.
about 10 to 15%.
All right. Did you actually read 50, 60% elsewhere for a recurrent hernia? For a stomal hernia? Yeah. You shouldn't quote
Yeah.
something without reading. Yeah, okay. Or you can just say, I'm guessing, sir. I agree, accept that also. Yeah, okay. What else? Is recurrence the only issue? Likith, you want to have a go at it? I've been very quiet today.
Sir, in Sugar-Baker technique, the mesh will rub against the bowel and might cause like erosion.
Nothing happens. No, that's not a problem. Okay.
So mesh
All right.
infection.
Yeah, you can. Infection. Yes, wound infection is much more common. What is very interesting is that we talk about using, many times these are polypropylene meshes. Some authorities use only a biological mesh. As you know, biological mesh is extremely expensive. So I usually use a polypropylene mesh. And very interestingly, even though a stoma goes through it, the mesh doesn't get infected. Very, very interesting phenomenon. I don't know why, but that's the situation. But then what you must, apart from a 10 to 11% recurrence rate, you must expect about 15-16% incidence of complications like infection, necrosis, obstruction, and mucocutaneous separation, where you've stitched up the hole. That happens not only in a repair of a parastomal hernia, but primarily in any fashioning of a stoma. It's no different. Okay, so these are the complications that one can expect. But interestingly, one must always say generally that the repair of a hernia, okay, has a recurrence rate of twice that much of, repair of a recurrent hernia the recurrence rate is twice as much as the primary repair of a hernia. Okay, that is something you must understand. So when people come to you for repair of a recurrence, then you sort of think that when you repair it, you will have a very good outcome, but in all probability, you will have a worse outcome than the first repair. The simple reason is that there is something inherently wrong with the patient's healing and the quality of collagen, and no amount of mesh reinforcement will completely compensate for that basic deficiency in the patient. So just remember, when you talk to a patient about repairing a recurrence, all right, just be aware that the recurrence rate or the complication of recurrence will be higher. Okay, any other questions or doubts?
No, sir.
Okay, so we will go to the next presentation, which is on safety in surgery. Many of you might have attended my talk on safety in the OT of AMC, which was done, I think, just 10 days ago or so. Any of you who did not attend that? All of you attended that? Any answers? I can't hear. Can you hear me?
Yes, sir. And
Yes.
few of us couldn't attend. We rewatched the video, sir. It is available.
Okay, all right. So
Yes.
anyway, the reason
Yes.
I asked is that some of the slides that I have used here are reused. The same thing, same slides that I have used in that talk I've used here. But the tilt or the approach here is a little different because it's not restricted to the OT. It has to do with surgery in general. It's obvious that surgery is an invasive specialty and errors have serious implications. And it's our job as surgeons to really, really minimize these errors. Okay. And I had a very sobering and a humbling experience this morning in my outpatients. Very interestingly, we have a checklist for preparation for endoscopy. A simple checklist that talks about patient being on an empty stomach, there being no dentures and allergies and the like. Okay, very simple checklist. And I had sort of not checked, and I take full responsibility for it. I had not checked if our nurses were checking it or not. Okay. And I saw this patient this morning, on my endoscopy table. I could easily see from a distance that this patient had dentures, completely artificial, completely normal looking, uniform teeth, dentures. And nobody had asked whether he had dentures or not. So I pointed out that this looks like dentures. They asked him after that, and then he took the dentures out, which was a very, very disturbing thought for me, that however much we talk about, I keep talking about surgical safety in so many fora, in so many areas, conferences and things like that. And in my own unit, I had this humbling experience. The reason I recount that in all honesty is the fact that unless all of us are constantly thinking about safety, constantly checking and double checking about our team doing what they're supposed to do, any amount of lecturing on safety is useless. Okay, please understand that we all have to always keep thinking about checking at all levels. It's not just at a consultant level, as a registrar, as a DNB student, as a trainee. We must be always thinking about uh, safety. Safety essentially means you must have systems in place. You must have protocols, you must have standard operating procedures, you must have systems in place. And even more important, we must make sure that those systems are followed. And this is where the big problem is. We may have many places don't have systems, but a lot more places, they don't follow the systems, even though the systems are in place. And somehow surgeons are lackadaisical about it, and that's what is very, very disturbing. And the consequences of not following systems is error. You have errors of omission in 1 in 100 cases, errors of commission in 1 in 300 cases. And the more the number of steps in a given process, higher are the chances of having errors. So imagine if you have a complex procedure like an operation, then your chances of having errors if you're not following a protocol is extremely high. And the consequences of errors are enormous. Okay, you may have missed or delayed diagnosis. There may be mistakes during the treatment part of it. I mean the medication part of it. There may be medication errors per se, delayed in reporting of results and taking action on those results. Very often that we ask for tests but never follow up the results. And those have to be followed up very, very diligently. And some action has to be taken based on those results. If you're not going to have that kind of follow-up, and if you're not going to act on those results, then you should not be asking for those tests. That is the important thing. Miscommunication is one of the biggest problems that we have. Really, it's completely underrated. We somehow do not talk to each other, the different doctors amongst themselves, consultants to juniors, juniors amongst themselves, juniors to nurses. We do not talk enough and confer and exchange information as much as we have to. And that results in inadequate post-operative care. Mistaken identity, of course, in an operation theater is a great disaster. But these are the kind of things that were recognized in the Institute of Health report of 2006. You remember that in the first decade of this century, there was a huge thrust towards surgical safety. Okay. Now, as I said, wrong identity is one thing, which is a wrong patient. Wrong site is another risk that one has. And of course, leaving behind foreign bodies like mops and things like that is extremely, extremely unfortunate. It should never happen if we have systems in place. Everybody talks about two things when we talk of surgical safety. One of them is the Swiss cheese model of errors. Second one is the aviation paradigm. Okay, two things. The Swiss cheese model, as you can understand, is very, very simple. There are several steps of safety in any procedure. A protocol ensures that. If a protocol is followed, what you will have is the second situation, what is in the bottom half of this picture, where the protocol is followed. Even if there is a miss in one step, the subsequent steps blocks it so that error doesn't occur. Whereas if that is not followed, or if you do not have a protocol, all these little mistakes or little deficiencies can align, and then the whole mistake carries through to the extent that the patient gets harmed. So the Swiss cheese model is something we should remember and make sure that we have several steps where we check and double check and triple check, make sure that errors do not occur. Now, if an error occurs, implications can hit the patient, it can hit the surgeon, it can hit the institution. Right? For the patient, it's of course complications. Then the obvious what follows is litigation and compensation. For the surgeon, it's a stress that one of his errors caused some harm, lack of self-esteem, and of course liability. For the system, for the institution, it's an important event, because it's the responsibility ultimately of the institution to have the system and the SOPs to make sure that errors do not occur. And so they must inculcate a culture of safety in the whole system, in the whole towards the whole set of staff, and to make sure that it is working, we must have an audit. Okay, and this is where the latter two is where we fail. In my own hospital, for example, we are NABH recognized and we have a whole lot of SOPs, but we do not audit regularly and we do not look at enforcement. And that is where we end up with a situation like I did this morning. So it's important that we should continue to audit, even before that, educate our staff on a regular basis, audit and ensure enforcement. Please note that near misses are a lot more common than actual errors. Near misses are what teach you, like it happened this morning, for example. They are the ones which teach you and give you a wake-up call to make sure that you avoid errors. Also note that 80% of episodes usually go unrecorded. So what you are seeing reported as errors in the literature is actually the tip of an iceberg. And you can see in all these reports that you have, I've given listed about 4 or 5 papers which tell you that the complication or the error rate leading to patient harm is as high as 98,000. This is an Institute of Medicine report in 1998. And the VA report talks about 10% complications and 2.8% mortality from surgical errors. And so it's also very important that nearly half of them, as you can see here, are preventable. Half of them are preventable. So it's important that we give a lot of importance to safety. Okay? From the institution's point of view, the only thing they should focus on is having protocols. Our systems, our methods are quite complex, even though they may seem very simple, like getting a consent for an endoscopy, for example. It is not that as simple as it seems. And so even extraordinarily committed people cannot remember every step perfectly all the time. And so you need to have checklists which they use diligently so that you don't miss things. And the systems approach is given to us by engineers, not doctors per se. This gentleman, Edward Deming, was an American engineer who worked in the Japanese auto industry. And he said that if you cannot describe your process, whatever you want to do as a systematic process through a protocol, then you don't know what you're doing. So just by breaking down everything that you do into several steps, just by giving standard operating procedures and checklists, this gentleman managed to get the kind of accuracy that the auto industry had, where when they manufactured a product, for example, a component in a car, their failure rate was 1 ppm, 1 part per million. If they made a million copies of a given part, only one copy or one of those products was wrong, and the rest of it was completely according to their requirement. That is a brilliant achievement that he did, in fact, in the 60s and 70s in the Japanese car industry. This gentleman, Jeff Cooper, is an engineer as well. He worked with Ellison Pierce, who is a consultant and an anesthetist. Both of them worked at Harvard in Massachusetts General Hospital, and they were the pioneers in putting systems in place. And Jeff Cooper's famous statement goes, safety is something that happens between your ears, not something that you hold in your hands, which essentially means that all of us must be thinking about safety all the time. And of course, I told you that the second thing that we talk about when we talk about safety, surgical safety, is an aviation paradigm. And this is the ultimate example of this. Okay, this guy had a failure of both engines due to bird hit as he was taking off from New York, and he was just powerless in the air, airborne. And because of the protocols that he had followed, because of the kind of situations he had experienced during his training, which they regularly do on the simulators, on the aviation simulators. This gentleman, Captain Sullenberger, managed to land his plane on the Hudson River with not a single loss of life. And so the institutional responsibility, coming back to our main topic, is to bring in SOPs and monitor safety. The other common thing that they mention when we talk about safety is to not blame people. If you blame somebody, an individual, they hide the mistakes that they do, which means that again the mistake may be done either by themselves or by somebody else. So the idea is to say, okay, you have made a mistake. Of course, you've got to reprimand them. You can't say, you'll say nothing. But instead of blaming an individual, we must look ourselves, introspect, and the institution must see if we can in some way improve the standard operating procedure. The protocol is a system of rules that explain the correct conduct of a procedure to be formal, to be followed in all situations. It's a step-by-step description of what needs to be done. It has several advantages. A protocol is automatically followed by a standard operating procedure. That's the protocol itself. Okay, it assures quality and consistency. If you have a written document, as I said, a protocol or an SOP is backed by a checklist. So all you have to do is diligently, honestly, keep ticking everything. The problem we have is that it's done as an exercise, not even thinking about what you're doing. You just keep ticking whether it's there or not. That's what gives trouble. But if you do it diligently, honestly, take it seriously, then it assures quality and consistency. It achieves good practice all the time, and it frees up time for other activities. Okay, it's done quickly because you don't have to recall and do one by one and go back to it and do it again. It has role clarification. Everybody knows what he or she has to do. And if you have newer people coming in, locum temporary staff or new staff coming in, they don't have to relearn everything from the beginning. They just have to know how to follow a checklist, and that will make sure that the process is correctly done. All right. So that is important. As I said, one of the important things that we miss out on, apart from the lackadaisical attitude towards a checklist, is communication. I think communication at every level is extremely important. As far as preoperative briefing is concerned, you must know about the patient's post-operative debriefings before you hand the patient over to the ICU or the post-op ward staff. And even in routine ward takeover, okay, there are many mnemonics that are used, many things that are used to help you remember. IPASS is one of them. S-bar is another one. IPASS means you must talk about the patient's illness, give a patient summary, give an action list about what's been done. Situation awareness is what is happening around the patient in terms of his social requirements, emotional requirements, and physical requirements. And S, the synthesis by the receiver. The receiver then has to absorb all this information and make sure that he understands what needs to be done in his part of the duty, maybe for the next 10 or 12 hours. So this is, it's easier said than done. We don't do this about all the patients, and it's something that we have to spend time on. We have a very quick takeover, handing over process in our systems, but it really needs an overlap of about half an hour or 45 minutes if you have about 10 patients. It's as simple as that. We need to have at least 3 to 5 minutes on each patient before you hand over completely. The other one I mentioned, effective communication, is S-bar, which is situation, background, assessment, and recommendation. This is what the person who is handing over the case to the next person should do. He should give a background to the case, tell them what the current situation is, give an assessment, an objective assessment of what the case is, and then give a recommendation as to what needs to be done in the next shift. Okay, so am I clear so far? Any questions or doubts or comments so far?
Clear, sir?
Nothing? You're clear about what I've said so far? Sanya, you have any comments to make?
No comments, sir.
No comments.
This is like in very detail, very important.
Yeah.
Every slide feels it's really important. Everything.
All right. So we next move on to the actual checklists. Okay. This is how a pre-op checklist looks in our hospital. Okay. I don't know if it's being followed in Sagar, but certainly we follow it in SHRC. Basically, it gives you, before the patient is sent to the OT, you have things like seen by the anesthetist. Okay. Pre-op check, patient's ID band being worn. Okay. Part being prepared, site being marked, and things like that. I have, as I said, we have this checklist. It's working. It's instituted. But I've had patients with deficiencies. I've had patients coming to the OT without their X-rays and investigations. I've had patients coming to the OT without the site being marked. Okay, it's just that sadly, our staff do not follow this diligently. And I really don't know what to do about it. It's just that it's a responsibility of every staff member to follow this honestly and diligently. We all know about this very famous WHO checklist. It really is an extremely important thing to do. And you won't believe this. In my own hospital, apart from my own unit and those of my colleagues, who are my trainees, okay, nobody else follows this. The OT nurse has been unable, in spite of the administration pushing the OT chief, the nurse has been unable to get the other surgeons to do it. And it's very difficult for, senior surgeons to be told what to do. It must come from within them to do it. And unfortunately, as I said, the reality is something which is unpleasant but true, that it's not being followed. But if you do follow it, diligently, you can reduce the mortality by 50% and morbidity by 30%. This is not a small thing. But I must say that this implementation challenge is not just in our institutions, not just in this country. It is universal. I've seen any number of papers from across the world which say that this implementation is a problem. And that is a human factor. It is something we have to learn to do. And so my suggestion or my recommendation or my request, if you want to call it that, is that at least the next generation, you people, follow it diligently and make sure that your system follows it. Site marking is a very, very simple process. Okay, the rule is very simple. There are no hard and fast rules, but the rule is simple, that if there is something which is bilateral, like a hernia, for example, okay, groin hernia, mark that site prominently where it can be seen easily, and make sure that the mark doesn't sit on the area of the incision. For example, you can put a mark either on the right foot or a right thigh for a right groin hernia, for example. So, but this site marking is something which residents must take responsibility for, make sure that it is done. The next part of the protocol is, of course, asepsis. Recognizing the right patient, the right operation, with all the equipment being right in the OT, is something that is looked after by the WHO checklist. But your OT design itself must be good. Okay, so you have the so-called clean corridor and the protected corridor, and a disposal corridor where the surgical waste goes after the operation. Hand hygiene is something very, very, very basic, very important. Okay, it's something which all of us must do. Have hand hygiene after every single patient contact. Before and after every single contact, you must exercise some kind of a hand hygiene. Personal protective equipment, safe injection practices, disposal of sharps, standard precautions, and antibiotic stewardship. These are all important, but they are, each one of them is a topic by itself. Standard precaution is a topic by itself. And it was extremely important when you have infective cases like HIV, COVID, and hepatitis B and the like. You can have another class on standard precautions some other time. It's an extremely important topic to follow. Equipment, as you said, today our OT is loaded with equipment, different kinds of equipment. I strongly urge our youngsters to look at all these equipment when there is no operation going on. When you have some time, go and look at these equipment. Look how they learn how to use them and how to do some kind of basic, um, you know, troubleshooting, as they call it. When something doesn't work, how do you look at it? How do you try and make it work? Is something that you have to learn in your spare time. This is about the technical aspects, but what is equally important is the non-technical skills for surgeons. I have mentioned it briefly. If you have attended the previous talk, you would know about it. If you have an opportunity to attend this course, please do it. I attended this course last year in Hyderabad, and it was quite an interesting course. Learned quite a bit from it. Basically, this was put together by a psychologist and a pediatric surgeon. I happened to work for that pediatric surgeon from the University of Aberdeen. My registrarship was in Aberdeen, University of Aberdeen. And one George Youngson was a pediatric surgeon who was working there, and I was with him for a couple of months working with him. He and another psychologist whom I don't know from the University of Aberdeen put together this beautiful document and established that it actually helps through data, that it helps in what it is supposed to do. And what it is supposed to do is based on these 4 pillars. This is about the non-technical aspects of behavior in the operation theater. I'm going to spend a few minutes based on this because this is something that is hardly ever discussed. Okay. And the 4 pillars are situation awareness, decision making, communication, and leadership. Each of these 4 pillars has 3 subdivisions to it. All right. Situation awareness, for example, talks about gathering information, understanding information, and projecting and anticipating future state. Very, very simple, but we have to be aware. When you have a situation in the operation theater, you must first gather the information. Somebody's blood pressure is low, for example. You must first know that the blood pressure is low. And then you look at what are these causes of happening. All this happens in quick time, even though I'm describing it step by step. Then you understand what is happening. Then you try to answer that. And at the same time, what are the consequences of hypotension? What should you do about it? So that kind of anticipating future state, that is situational awareness. So once you understand this, then there's a decision making. What are the things I can do? Should I deflate the abdomen if I'm doing a laparoscopy? Should I increase the IV fluid? Should I start an inotrope? You as a leader of the team, okay, in consultation with the team. Again, teamwork is something that is really stressed in this knots or the non-technical skills. In consultation with your registrar, for example, and the consultant anesthetist, you then say, okay, we are going to do this. Consider the options and then you select one of those options. You will have 2-3 options at a given time. Select that and say, this is what I have selected. This is the option I have selected. And this is what I would like all of us to do. And then you implement it and then review the decision. You implement it and see if the patient's condition has improved. And communication and teamwork here is extremely important. You exchange information, you have shared understanding, you allow people to talk, you take their views, and then you coordinate the team activities. And as a leader, you have to make sure that all this is done in a friendly and understanding manner, setting and maintaining standards. You have to cope with pressure and you have to support others. Not every team member may be as cool as you are. You should be cool yourself first as a team member, as a surgeon, and you must support others in doing what they have to do in an area of difficulty. So they go on to describe various situations, and in that course, and it was a very, very interesting course. There's also some role plays and things like that. It was really a very, very revealing thing. For example, in that aspect of gathering behavior, they list some good behaviors and some bad behaviors. I'm not going into each one of those, okay? But it's as simple as this: ensures that all relevant investigations have been reviewed and are available. You can't walk into a theater as a surgeon not knowing what the LFT is before you do a gallbladder, for example. So at least before you start your WHO checklist, that's what I do. I ask my assistants if everything is okay, and then check with it. If we write everything on the board, on the whiteboard, I check all those things, and then we start our WHO checklist. Poor behaviors, very first thing, arriving late to the theater. Okay, the very first thing. Not talk about the results until you actually faced a problem. And then you can understand, not present for the surgical pause. It's a very, very important thing. You, as a surgeon, you have to stay back and make sure that you are there when you do the checklist. This is another interesting thing. Fails to listen to the anesthetist. No, honestly, I've always felt that if anything surgery has taught me, it is humility. There are no great surgeons in this world. There are no super surgeons, and you can be in situations where you can be in trouble at any stage of your career. So you have to remain humble with your feet firmly on the ground and listen to people. You may not agree with them. You may not agree with your registrar telling you something, but you cannot stop him from saying. You should not stop him from saying, because he has a role as a team member. The anesthetist has a role. The scrub nurse has a role. There are any number of times when my nurse in the OT has given me suggestions, and I do, and I accept it. I listen to it with all humility. I may accept it or not accept it. That's a different issue. Okay, understanding information acts according to the information gathered in the operating findings. If you have prejudiced and you say there is something that you have decided that something has to happen in a particular way, not going by the data that is staring you in the face, then there's a real problem. Okay, that's a bad thing. So you have to act according to the information you have gathered and the investigations. And this is an important point here. Bad behavior is when you discard the data, discard the results that do not fit the picture that you have in your mind. The data should create the picture. And the picture should not be presupposed or prejudged. That's a very, very important lesson to have when you're operating. Okay, anticipating future course shows evidence of having a contingency plan. What do you do? Plan B. If you have spent time with me in the OT, I keep asking, or anywhere else, I keep asking my trainee, what do you do if that doesn't work? What do you do if that doesn't work? What happens if basically I'm asking, what is your plan B and plan C? So you must have that kind of thinking process when you do everything, every move that you have. Okay, overconfident maneuvers with no regard to what may go wrong is a deadly thing. It's literally deadly. You can get into situations where you cannot retrieve, and even others can't come and help you. So it's very, very important that you anticipate the results of your moves and have plan B and C. Shared understanding is something which I cannot overemphasize. As I said, you must make time for collective discussion and review. Talk to your colleagues, talk to your anesthetist colleague, talk to your surgical colleague, listen to them and make a joint decisions. Encouraging inputs from members of the team ensures relevant members of the team are happy with the decisions. If you bulldoze your way through, then the whole purpose of communication is lost. You have to allow people to talk. Hierarchy is important to some extent. If there is, if you're leaderless, then if there is nobody who's asking for things to be done and no followers, then there is chaos. So there must be leadership. There's no doubt about it. But leadership does not mean dictatorship. That is the important thing. Even though everybody knows that the surgeon is the leader of the team, Everybody has to respect him for what he is. But at the same time, he should not be like a dictator who's not approachable, who cannot be talked to. Every person must be allowed to speak, and it is the duty of the surgeon as a leader to justify in all humility the decision that he takes before he undertakes that act or the decision that he has made. So to take home message in all this, very simple. Surgical error occur more often than is generally accepted. Near misses are common, so please be aware of it, recognize it, talk about it in the team because it is a great opportunity for learning. Near misses are where the patient is not harmed, but some error has occurred, and so you have to learn from it so that the same error doesn't occur again. Change from blame game to analyzing and improving the SOPs, the standard operating procedures. While individual surgeons should take responsibility for everything that happens in his or her unit, it is important that systems have to be in place. And all of us should work towards putting these systems in place. If they are not in place, we should start working on it and putting them in place. Enforce adherence to the processes. This is a big, big challenge. And another challenge is proactively audit our work to make sure that we really do remain safe at work. So I come back to Edward Deming in my thank you slide, when he says, if you can't describe what you're doing as a process, you don't know what you're doing. So simple message, have a protocol for everything, have a standard operating procedure, and have a checklist and follow it regularly. Thank you for your comments and questions.
So it's a very structured approach, sir, actually. Like it sounds very day to day things which we do consciously and unconsciously, but knowing them in a stepwise order actually makes a difference. Yes, sir.
So it really is, that's true. As I said, you must have standard protocols for everything. Everything, putting up an IV, putting up,
Yes.
introducing a urinary catheter, getting a consent form, getting a consent sign, routine stuff, but there must be a protocol.
Yes, sir.
Yeah, and that is something
So
that
that
all
can
of
be
us.
easily carried forward to the yes.
Mahati here. I haven't heard your voice today. Your comments.
Sir, I understood, sir.
You understood.
Very.
All right. So what did you understand? Give me my take-home message. 3 points from my last slide.
So, follow the protocol.
Okay. Have the protocol first.
Yes,
See
sir.
the protocol. Okay. How do you follow the protocol?
So, documenting each and every step will help, I guess.
How do you know that you have followed all the steps of a protocol?
Communicating
Checklist.
checklist.
You
Yes.
have a checklist which explains the steps of a protocol. Yeah. Honestly, read and tick it only if it is done. That is the important thing, not mechanically. Okay. What else? Should I put it up again? My take-home message? What happened? So quickly. All right. Go on, read it. So this is
Surgical
very
errors.
important. Go on.
Surgical errors occur more often than is generally accepted.
Yeah.
Near misses are very common. Also offer an opportunity.
For what?
For serious damage.
Opportunity for damage. Illama. They give
Near
you an opportunity for what? What are near misses?
So, which do not actually cause damage, but if anything changes,
An error
will
has
result.
occurred, you're right, an error has occurred, but it does not damage the patient. Okay, so what does it offer an opportunity for? It offers an
For
opportunity for rectification. Correct. So it gives you an opportunity to set the process correctly, set it right, so that the error doesn't occur again. Okay, next one.
Change from one of blame to one of analyzing.
Yeah, so don't blame people, analyze the situation and correct it. Okay.
Yes, sir. While individual surgeons should take responsibility, it is important to realize that systems have to be in place.
Yeah.
We should all work towards putting systems in place, enforce adherence to processes and checklists,
Yeah.
and proactively audit our work to document safety at work.
Yeah. What is an audit?
So it's like, is it like an inspection?
Okay. What does it do?
To check the system whether it's going on
All right.
correct.
Someday we'll have a class on an audit. Okay. Yeah, we will
Okay.
learn more about it. Okay. All right. Any other comments, questions from students? All right. Closing remarks from Sanya before we close. Yeah, before we stop the session. Yeah.
So as I said, looks like very simple, but it is very significant. In each every step is significant for us, both for our safety as well as patient safety. So very nice, very detailed talk. Like the class very much.
All right. Okay. Thank you and good night. I'll stop.
Good night.
Good night.